The pain that radiates along your lower back through one side of your hips to buttocks and down to the leg. It's typically the pain associated with the medical condition known as sciatica. Hi, this is Adel Hajjaj from the Anatomist. In this channel, we are helping medical students and people to understand and enjoy human anatomy. If you are new here, consider subscribing. So, what is sciatica? It is lower back pain caused by sciatic nerve root compression, usually after a history of injury that leads to disc herniation, and most commonly at the lumbar region between L5-S1, L4-L5, and L3-L4. The pain widely varies from a mild ache to a sharp burning sensation or excruciating pain. Sometimes it can feel like an electric shock. It can be worse with coughing and sneezing and prolonged sitting. Sciatica gender presentation ratio is 3:1 male to female. Disc herniation at the level of L4, L5, and L5-S1 are the most common, and they account for 95% of all disc herniations. Only 5% become symptomatic. Generally, sciatica has some unique epidemiologic characteristics. Peak incidence occur in patients in their fourth decade, lifetime incidence reported between 10% to 40%, and annual incidence of 1% to 5%. No association with body height has been established except in the age 50 to 60 group. It rarely occurs before age 20 unless secondary to trauma. Some studies suggest a genetic predisposition. Physical activity increases incidence in those with prior sciatic symptoms and decreases in those with no prior symptoms. Occupational predisposition has been shown in machine operators, truck drivers, and jobs where workers are subjected to physically awkward position. Symptoms of the sciatica are varied, including back dominant pain in case of central disc herniation or leg dominant pain in case of lateral disc herniation, tenderness between spinal processes at the affected level, muscle spasm with or without loss of normal lumbar lordosis, neurological disturbance according to the level of the central herniation, motor weakness or loss of power in the lower extremity L4, L5, S1, diminished reflexes L4, S1, diminished sensation L4, L5, S1. The straight leg raise test or SLR test is the pain going into the buttock and below the knee when the leg is raised above 60 degrees. It's good to know that mild sciatica usually goes away over time, but get immediate medical attention if you have a severe pain in your lower back or leg and numbness or muscle weakness in your leg. The pain follows a violent injury such as a traffic accident. You have trouble controlling your bowels or bladder. For better understanding, let us do some anatomical explanation. The vertebral column is composed of 33 to 34 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 fused sacral, and 3 or 4 coccygeal. Because it's segmented and made up of joint and fibrocartilage cushions called intervertebral disc, it is a flexible structure, and their physical characteristics permit them to serve as shock absorbers when the load on the vertebral column is suddenly increased, as when one is jumping from a height. Unfortunately, their resilience is gradually lost with aging. Each disc consists of peripheral part, the annulus fibrosus, and a central part, the nucleus pulposus. The annulus fibrosus is composed of fibrocartilage in which the collagen fibers are arranged in concentric layers. The nucleus pulposus in children and adolescents is an oval mass of gelatinous material containing a large amount of water, a small number of collagen fibers, and cartilage cells. The semi-fluid nature of the nucleus pulposus allows it to change shape and permits one vertebra to rock anteriorly or posteriorly on another as inflection and extension of the vertebral column. A sudden increase in compression load of the vertebral column causes the semi-fluid nucleus pulposus to become flattened. The outward thrust of the nucleus pulposus is accommodated by resilience of the surrounding annulus fibrosus. Sometimes the outward thrust is too great to the annulus fibrosus and it ruptures, allowing the nucleus pulposus to herniate and protrude into the vertebral canal, where it may press on the spinal nerve roots, the spinal nerve, or even the spinal cord itself. With advancing age, the water content of the nucleus pulposus diminishes and is replaced by fibrocartilage. The collagen fibers of the annulus fibrosus degenerate, and eventually the annulus fibrosus cannot always contain the nucleus pulposus under stress. In old age, the discs are thin and less elastic, and it's no longer possible to distinguish the nucleus from the annulus. The sciatic nerve is a branch of the sacral plexus out of the nerve root value of L4, L5, S1, 2, and S3. The sciatic nerve leaves the gluteal region as it descends into the midline of the thigh, and it's overlapped anteriorly by adjacent margins of biceps femoris and semimembranosus muscle. It lies on the posterior aspects of the adductor magnus muscle. In the lower third of the thigh, it ends by dividing into the tibial and common fibular nerve. Occasionally, the sciatic nerve divides into its two terminal branches at a higher level, sometimes in the upper part of the thigh, the gluteal region, or even inside the pelvis. Accordingly, knowing the sciatic nerve distribution will help us explain and understand the sciatica symptoms. So let us do this. Distribution of the sciatic nerves. Articular branches arise proximally to supply the hip joint through its posterior capsule. Muscular branches are distributed to the hamstring area, biceps femoris, semitendinosus, semimembranosus, and the ischial part of the adductor magnus. And this group of muscles acts as the hip extensors and knee flexors. The tibial nerve is the larger component of the sciatic nerve, derived from L4, 5, S1, 2, 3, and ends under the flexor retinaculum by dividing into the medial and lateral plantar nerves. It gives articular branches to the knee joint, superior tibiofibular joint, and inferior tibiofibular joint, and muscular nerves that supply the superficial layer of the posterior compartment of the leg, gastrocnemius muscle, plantaris, and soleus muscle, and supply the deep layer of the posterior compartment of the leg, tibialis posterior, flexor digitorum longus, flexor hallucis longus, and popliteus, and via medial and lateral plantar branches supply the muscles of sole of foot. Sural nerve or sural nerve supplies skin on the lateral side of the leg and foot. On the other hand, the common fibular nerve or the common peroneal nerve, this is the old name, is approximately half the size of the tibial nerve and is derived from L4, L5, and S1. It gives two terminal branches, deep and superficial fibular nerve. It gives articular branches to the superior tibiofibular joint and ankle joint, and via deep fibular branch supplies the anterior compartment of the leg, tibialis anterior, extensor hallucis longus, extensor digitorum longus, fibularis tertius, and extensor digitorum brevis, and the skin over the cleft between the first and second toes, and via the superficial fibular branch supplies the lateral compartment of the leg, fibularis longus, and brevis muscles, and skin over the lower third of the anterior surface of the leg and dorsum of the foot. Risk factors of sciatica include age. One of the most common causes of sciatica is the age-related changes in the spine, such as herniated disc and bone spurs. Obesity, excessive body weight can contribute to the spinal changes that trigger sciatica by increasing the stress on the spine. Occupation, a job that requires you to twist your back, carry heavy load, or drive a motor vehicle for long periods might play a role in sciatica. Sitting for a long time of period. People who sit for prolonged periods or have a sedentary lifestyle are more likely to develop sciatica than active people. This medical condition increases the risk of nerve damage. During the physical examination, the doctor will check your muscle strength and reflexes. For example, you may be asked to walk on your toes or heels, raise from a squatting position, and while lying on your back, lift your legs one at a time. Pain that results from sciatica will usually worsen during these activities. Doctors don't typically order imaging tests unless your pain is severe or it doesn't improve within a few weeks. In this case, the following tests may be applied. X-ray. An X-ray of your spine may reveal an overgrowth of bone spur that may be pressing on a nerve. MRI. An MRI produces detailed images of bone and soft tissues such as herniated discs. CT scan. When a CT scan is used to image the spine, you may have a contrast dye injected into your spinal canal before the X-rays are taken, a procedure called a CT myelogram. The dye then circulates around the spinal cord and spinal nerves, which appear white on the scan. Electromyogram. EMG. This test measures the electrical impulses produced by the nerve and the responses of your muscles. This test can confirm nerve compression caused by herniated disc or narrowing of the spinal canal in case of spinal stenosis. Although the pain associated with sciatica can be severe, most cases resolve with non-operative treatment in few weeks. People who have a severe condition with significant leg weakness or bowel or bladder changes might be candidates for surgery. How can we manage or treat sciatica? Well, the first line of management is actually conservative management, which includes taking painkillers such as non-steroidal anti-inflammatory drugs or NSAIDs, example ibuprofen and naproxen, with the continuation of ordinary activities. No bed rest. Staying active such as doing yoga and other back exercise is the most effective. Second line of management. Steroid injection into the epidural space achieves rapid and dramatic benefit for those with sciatica who do not improve with the conservative management. 90% of patients improve in 3 months with non-operative treatment. Third line. After that comes operative management, which only indicate in rare cases of progressive neurological deficit, failure of symptoms to resolve within 3 months, Coda-Iguana syndrome due to central disc herniation. The operation called surgical discectomy, which is a surgical procedure that removes the damaged portion of the herniated disc in the spine. It's not always possible to prevent sciatica, and the condition has a recurrency features. The following can play a key role in protecting your back. Exercise regularly to keep your back strong. Pay special attention to your core muscles, the muscles in your abdomen and lower back that are essential for proper posture and balance and alignment. Maintain proper posture when you sit. Choose a seat with good lower back support, arm sits, and a swivel base. Consider placing a pillow or rolled towel in your lower back to maintain the normal curve. Keep your knees at the hip level. Mind your body mechanics. If you stand for long periods, rest one foot on a stool or small box from time to time. When you lift something heavy, let your legs do the work. Move straight up and down. Keep your back straight and bend only at the knees. Hold the load close to your body, avoid lifting and twisting simultaneously. Find a lifting partner if the object is very heavy. Thank you very much for watching this video. If you like it, hit the like button, subscribe to the channel, share it with your colleague. See you in the coming video.